Good evening, everyone. Thank you so much for joining us for this exciting event on breakthroughs in HR positive metastatic breast cancer management and Asia perspective. We have a great panel of experts today for you. And next slide, Kushi. So before we start the event, I would like to run through some housekeeping announcements. Please do check that your connection is stable. For optimal sound quality, a headset is recommended. And finally, this webinar is being recorded, so your participation serves as consent for the same. So next slide, Kushi. I am deeply honored to introduce our chairperson for the day, Dr. Nelly Chia, who's a consultant clinical oncologist from Lo Guan Lai Specialist Center, Malaysia. Dr. Nelly obtained ASEAN scholarship to study A-levels in Singapore, and then an Australian government scholarship to study medicine in the University of Melbourne, Australia. She obtained her MRCP and FRCR training and qualifications in United Kingdom. She was then admitted to the General Medical Council Specialist Register in Oncology, and she's experienced in chemotherapy, targeted therapy, and radiotherapy treatments. She has worked as a locum consultant in Queen Elizabeth Hospital in Birmingham, UK, before returning to Malaysia, serving at Hospital Pulau Pinang, which is a government hospital in Malaysia. Currently, she's a consultant oncologist and radiotherapist in Lo Guan Lai Specialist Center, Penang. So welcome, Dr. Nelly.
Good evening, everybody. Thank you for giving up your time on a Friday evening to learn something more about hormone-positive metastatic breast cancer. I'm very thankful for AstraZeneca for organizing this event. And for this evening, we have got a multi-country speakers and panelists from Germany, from India, from Taiwan, to actually share the experience and knowledge among all of us. So the objectives for these meetings are really to discuss about the latest advances in hormone receptor positive metastatic breast cancer treatment landscape, focusing on new therapies and biomarkers, and also to share among all of us the real-world experience on the use of therapy and outcomes of the advances. I think in the past, we used to say in metastatic hormone-positive breast cancer, it's a hormone treatment, and it's one size fits all. But it is no longer the case. There are many biomarkers, many emerging treatments, which makes us a very important part of the process, of the journey of giving personalized treatment to patients with hormone-positive metastatic breast cancer. And I think among the audience, we have got more than 300 participants from many countries, such as India, Taiwan, Malaysia, and also I understand from Jordan and Egypt as well. So today, our agenda will be consisting of 15 minutes presentation by Dr. Akhil Santosh on the current management in hormone-positive metastatic breast cancer. Where are we now? Followed by Professor Cheng from Taiwan on the mechanisms of endocrine therapy resistance. And I think this is a very, very important part of our learning experience about how to use the drugs. And then we've got Professor Nadia Harbeck for 30 minutes in terms of optimizing outcomes in the hormone-positive, HER2-negative metastatic breast cancer, and followed by case-based panel discussion among all the panelists. So without much further ado, I would like to introduce our first speaker, Dr. Akhil Santosh from India, and he's a consultant medical oncology from MVR Cancer Center Research Institute, Calicut in Kerala. And he completed his MD from PGIMER Chandigarh and DM in medical oncology from AIIMS New Delhi, and he brings a wealth of knowledge and expertise to his field and has experience in managing various malignancies, including breast and genitourinary tumors and the thoracic malignancies. He's completed his MRCP from UK London and is ECMO certified and has got numerous publications in his names and has presented at various international congresses. So without much further ado, I would like to welcome Dr. Akhil Santosh for a presentation on current management in metastatic breast cancer. Where are we now? Dr. Santosh.
Thank you for those kind words. Just let me take a second to share my screen. Hope I am audible.
Yes, sir.
Are my slides visible?
Yes.
And are they moving? Yeah.
Yes, sir.
Yeah. At the outset, I would like to thank the entire team of AstraZeneca and to the chairperson and the entire organizers for giving me the opportunity to present. And I would like to apologize that Dr. Batrash could not be here for the initial part of the presentation because of an unforeseen emergency. So I will be covering on his behalf. So the topic given to me is the current management on hormone-positive metastatic breast cancer and where are we now. So this will be a very short presentation. So I would not be delving much in detail to each and every specific trial. So I would be giving a brief overview of the different first line, second line, and third line and beyond options. What we have currently in the management of metastatic hormone-positive breast cancer. So this is something that we all know. So around 70% of all breast cancers are hormone positive and HER2 negative, and around 60% of those. So that means around 60% of HER2 negative breast cancer cases are now classified as HER2 low. So this, as you all know, is a relatively new entity. So HER2 low is any tumor that is IHC 1+, 2+, or FISH negative. And this is something that we know that the 5-year relative survival in patients with the hormone positive HER2 negative is to the tune of around 35 to 40%. So this has increased from around 20 to 25% around 10 years back. So we have made tremendous strides forward in this subset. So the treatment of hormone positive HER2 negative is not a one size fits all approach. The treatment has been expanding at a very rapid pace, and it is ever so nuanced and individualized. So it all depends on various factors like your tumor biology, all the prior therapies the patient has received before, and the time to progression on each therapy, and what is the stage of the stage of the patient, and whether he has any visceral metastasis. Is he in is the patient on is in any sort of visceral crisis? What is the comorbidities and the PS of the patient? And on most important, the patient choice or the patient and the patient preference. So all these factors should be taken into account when you're planning therapy in metastatic hormone positive breast cancer. So this is just a brief snapshot. Basically, takes you way back to 1970s, where it had all started, right from the first approval of tamoxifen. So that is in fact a very that is in fact very long back. So tamoxifen, as you all know, is the first selective estrogen receptor modulator that was approved in the treatment of breast cancer. After tamoxifen came anastrozole. So this was basically based upon a phase 3 trial, which was done in the metastatic postmenopausal breast cancer hormone positive patients, where anastrozole had a DFS benefit, a PFS benefit over tamoxifen. Then came your selective estrogen receptor downregulators in the form of fulvestrant by the turn of the century. Then 10 years, and then for another 6 to 8 years, there was not much progress. Then you came your mTOR inhibitors with introduction of everolimus and exemestane through the Bolero 2 trial, which had shown a survival benefit for this combination. And cut short to 2015 and 16 comes the era of the novel CDK4 inhibitors with the arrival of palbociclib, ribociclib, and abemaciclib. Then comes the introduction of your various PI3 inhibitors and your oral SERDs and your ESR1 inhibitors. And there has also been interest in therapeutically exploiting the BRCA pathway with the introduction of PARP inhibitors. So let me just take you back to tamoxifen. Just very brief overview on each class of drugs. Tamoxifen, this is something that we all know. Tamoxifen is a SERM. How does it act? It mainly acts through competitive binding to the estrogen receptor, and it has agonist and antagonistic options. Antagonistic activity means that it is agonist in certain tissues and antagonist in certain other tissues. In the breast, it is an antagonist. In the uterus and the bones, it is an agonist. So this mainly leads to different sort of a side effect profile. So basically, they can cause side effects like your depression, fluid retention, anemia, cataracts, and it has also a slight increased risk of endometrial cancer due to its agonist activity in the uterus. We all know the mode of administration is oral, and it has been widely used in different indications in postmenopausal, adjuvant, metastatic settings. So I will not be discussing much in detail. Then comes your anastrozole. It works by a different mechanism, basically by preventing the conversion of androgens to estrogen by inhibiting the aromatics. And we all know about the head-to-head trial with tamoxifen showing a superior PFS benefit for anastrozole. So remember that there was no OS benefit in this. And side effect profile is slightly different compared to tamoxifen. This mainly causes your fatigues, myalgias, your GI disturbances, your lipid profile abnormalities. And the AIs, they act in such a way that continued administration of the same can lead to the emergence of multiple mechanisms of resistance. So this is where your ESR1 comes into play. And yeah, so coming to fulvestrant. So fulvestrant, as you all know, is a selective estrogen receptor degrader or downregulator, and exerting selective ER downregulation and competitive binding to the ER. So basically, you need to be aware of three important initial trials in fulvestrant. So the first trial is confirmed trial. So the confirmed trial was the initial dose finding study, which had found a superior activity for the 500 mg dosing of fulvestrant compared to the 250 mg. Then coming to your Falcon trial, where they had tried fulvestrant against anastrozole in the first-line management, which has shown a PFS benefit with fulvestrant. Then your Parsifal trial. So what is the Parsifal trial? Parsifal trial is a relatively newer trial in the era of CDK4 inhibitors, where they had tried CDK4 plus AI versus CDK4 plus fulvestrant, where there was not much overall survival benefit with the addition of fulvestrant as a first line, in the first line setting. Again, side effect profiles, they are mainly related to your injection site reactions and your other GI disturbances, arthralgias, and hot flashes. And limitations, again, as a monotherapy, it has relatively lesser activity and compared to the other newer drugs, and it has very limited activity post CDK4 inhibitors, and it is not very active against the most common ESR1 mutations, namely your Y537S, which accounts for around 30 to 40% of your ESR1 mutations. So this is something that we all are tuned to. We all know that patients, as they go through the therapeutic paradigm of metastatic hormone positive breast cancer, they tend to derive slightly lesser benefit from the hormonal therapies, and at a point in the patient's pathway, they become lesser active and active lesser. They derive lesser benefit from these therapies. At this point of time, you might have to resort to second line therapies, including regimens that target your ESR1 PIK3 pathway or your novel ADCs or your anti-HER2 drugs and your other ADCs like your SG, target SG and datopotamab deruxtecan. And at the end, you might have to resort to chemotherapy options. So, sure, a nice slide depicting all the different lines of treatment options. So, in the first, I would be discussing each in detail. So, as the first line, so let us focus on the standard of care. So, what is the standard of care? They are mainly your CDK4 inhibitors along with AI or fulvestrant. So what are CDK4 inhibitors? So CDK4 inhibitors, mainly they are those class of drugs which competitively binds to your CDK4, preventing the phosphorylation of your RB, and which in turn prevents the progression of the cell cycle. So there are three main important drugs in this class, Palbo, Ribo, and Abima. And there are slight pharmacokinetic differences between these drugs in the fact that, to name a few, Palbociclib, it has got relatively more action on CDK4, CDK6 rather than CDK4. It is a less potent CDK4 inhibitor. So this might in turn reflect in its side effect profile, with palbociclib showing a slightly higher incidence of neutropenia compared to the other drugs. And the most potent among these three is ribociclib, with effect to the relative CDK4 / CDK6 inhibition. And some salient features about abemaciclib is that abemaciclib, it inhibits various other cyclin-dependent kinases apart from your CDK4 and CDK6, like your CDK2, CDK9, CCNE1, and it has got a continuous dosing schedule compared to the other two drugs, and it has got a superior CNS activity and a better tissue penetration. So these are some salient features with abemaciclib. And so these are the three landmark trials which have tested CDK4 inhibitors in the first line in metastatic hormone receptor positive subsets. And we have the Paloma 2 with palbociclib, Mona Lisa 2 with ribo, and Monarch 3 with abemaciclib. So what is common among these trials? If you can see the three Kaplan-Meier curves, so there is a clear early separation in the PFS curves. So this is common to all three. And you can see that the relative decrease in the risk of progression is the same, and which is reflected by the similar hazard ratios for all these three trials. And the median PFS is almost the same, almost 2 years for all these three drugs. But unfortunately, in the longer follow-up, only the ribociclib trial had shown an overall survival benefit, with Mona Lisa 2 hitting the OS. And Monarch 3 had slightly missed the overall survival mark, and the hazard ratio was slightly crossing what, and the same was with palbociclib. So this is a beautiful slide depicting the different progression-free survival benefits for each class of drugs, right from your AIs, which gives you around 1 year of a PFS. With fulvestrant in the Falcon trial, it was slightly better. Again, there was no overall survival benefit over an AI. Then comes your CDK4 inhibitors with a PFS of around 2 years. So this is another important slide that I want to highlight, that your the first line therapy gives you a good PFS of around 2 to 2.5 years. But once the patient progresses on your first line, the subsequent, we need to do really better when it comes to the subsequent lines of therapies. This is reflected in the values of the PFS that you can see in second line and beyond. It's hardly around 5 to 10 months. So this is an area where we need to really put in efforts. So these are a few novel strategies that are being tried. So for one is your wait and switch approach. So this is mainly seen with the two trials, the PADA one and the Serena 6. So PADA one is a slightly older trial, just published around 4 5 years back in the Lancet. So here what they have shown is that they have started the patients on CDK4 and AI, and they have serially monitored the patients for the emergence of resistance mutations in the form of ESR. So they had done lipid biopsies at periodic intervals, and on the emergence of a ESR1 mutation, they had switched the AI partner. So basically, they have changed AI to fulvestrant. So they have shown that this sort of a strategy had a PFS advantage. So in the PADA one, the the PFS advantage was around 5 to 6 months. It was around 11 months versus around 6 months. So the same was seen in Serena 6 trial. So in the Serena 6 trial, the design was entirely the same. They had started on CDK4 AI, but instead of switching to fulvestrant, they had switched to a novel uh, oral SERD, which is camizestrant. So again, this was the trial was recently published in NEJM, presented in ASCO 25. The PFS was around 16 months versus 9 months, around 7 months of PFS advantage. But again, the trial had a lot of criticisms of its own. Some of them were it was very cumbersome to test lipid biopsies at periodic intervals. It is a painstaking process. It requires logistics of its own. And also, if you go into the trial in detail and in the discussion part, you can see that the patients in the camizestrant arm, they had received a slightly higher percentage of post-progression ADCs, post-progression chemotherapies. And some even claim that even after the emergence of a resistance mutation, the control arm with only an AI may be suboptimal. So these are some of the caveats associated with the Serena 6. And coming to the other novel SERDs in the first line, these trials are not yet out. They are currently accruing. They are mainly the Serena 4, testing camizestrant with palbociclib in the first line, Persevera and Pioneer testing giredestrant in the first line. And in the triplet therapy, in the first line, we also now have the approval of inavolisib. So inavolisib is a novel PI3K inhibitor. It is a selective mutant degrader of PI3 alpha. And so in patients who have progression within 1 year of completion of adjuvant or during adjuvant endocrine therapy, if they have a mutation of a PI3, they have these patients, they have been found to have an overall survival benefit with this specific triplet approach. So recently, the overall survival results were out and they were published in NEJM and presented in ASCO. So around 6 to 7 months of OS benefit was there for this upfront triplet therapy combination. And again, Capitello 292 is a novel trial testing capivasertib in the first line. So we all know about the Capitello 291, where capivasertib was tested in the second line against fulvestrant. So 292 tests capivasertib in the first line, the results of which are not yet out. So coming to the second line and beyond treatment options, once the patient progresses, it is ideal that you test the tumor or the blood for emergent resistance mutations. So what are those? So basically they are grouped into three. One category is your PIK3, AKT, and PTEN. All these three mutations together make up for around 50%. The most prevalent of them is PIK3CA, which accounts for around 40%. What's the main difference with the mutation dynamics between PIK3 and ESR1? So ESR1, we all know that ESR1 at the baseline, the incidence is hardly less than 10%. But during the course of time, the incidence can rise to almost 40 to 50%. So this is not the case with PIK3. So PIK3 is basically the mutations and they are stable over the disease course. But again, with the patient prognosis, it is bad for all the three. For BRCA, PIK3, and ESR1, they have a negative prognosis. They are all negative prognostic factors, and patients have poorer survival. And the BRCA, as you all know, the incidence is around 5 to 7%. They are stable over the course. In fact, they are inherited and they are aggressive. And we have two trials, mainly your Olympiad and the EMBRACA trials, testing olaparib and talazoparib in this setting. So they have not taken hormone positive patients as such. The trials have taken both hormone positive and TNBC, but the majority patients were hormone positive. And coming to ESR1, we all know that there are different classes of drugs targeting ESR1, right from your SERDs to SERMs, and there you have novel Protax, Sercas, and Serans. So recently the Protac drug vepdegestrant was the data was presented in the recent ASCO and published in NEJM in the VERITAC-2 trial, where it had showed a benefit over fulvestrant in the ESR mutated patients. And now coming to the third line and beyond. So this is something that I already alluded to. As the patients continue in their treatment journey, they derive lesser and lesser benefit from hormonal therapies. At this time, you need to switch them to newer therapies. So what are these newer therapies? So basically, they are your ADCs. So what are the different ADCs that have been tried and tested in hormone positive subsets? So I will be discussing three in detail. So one is your trastuzumab deruxtecan. So we all know this is a new kid in town. So this has shown benefit in the HER2. Initially, it was shown benefit in the second line and third line HER2 positive. And later on, they are come into the first line HER2 positive. They are also shown benefit in the HER2 low and your ultra low subsets. So you can see that around 60% of hormone positive patients, they are actually HER2 low. So this is your uh, target group where they might benefit from your ADCs beyond CDK4 inhibitors. So there are two trials. One trial is Destiny-04. So Destiny-04 had taken only HER2 low patients. They have taken TNBC and hormone positive patients. So Destiny-04 had shown a PFS of around 9 to 10 months with TDXD, and but the overall survival results were still immature. And then comes your Destiny 06. So Destiny 06. So what is the difference between Destiny 06 and Destiny 04? Destiny 06 had purely taken hormone receptor positive patients. They have not taken TNBC, and uh, patients who were chemo naive were allowed to be enrolled in Destiny 06. So basically, you could start TDXE as your first systemic chemotherapy. So Destiny 06, the PFS was around 13 months, and it was same in the HER2 low, as in I mean to say that the PFS delta, so that was same in the HER2 low and in the ultra low subsets, and the overall survival results are still immature. And coming to your next category of ADC, so that is your datopotamab deruxtecan. The mechanism of action is almost similar to trastuzumab deruxtecan. There is a slight difference with respect to the side effect profile and the drug antibody ratio. And but in the TROPION-Breast01, one highlight is that the patients were heavily pretreated. Even patients who were enrolled in this trial had received 1 to 2 lines of prior ADC therapy also. And there was around 2 months PFS delta benefit with datopotamab deruxtecan. But unfortunately, there was a recent OS readout of this trial which had stated that Dato did not have an overall survival benefit. So there were many criticisms that were raised, mainly the heavily pretreated population and your patients receiving prior ADC, and the fact that, the response of an ADC after an ADC may not be that optimal. So these might be the reasons that Beto did not have an overall survival benefit. And who knows, it might it would have had if it was tried in a much earlier setting. We never know. And regarding the side effect profile, if you take your interstitial lung disease into account, the incidence of ILD with Dato is slightly lesser compared to TDXT, but your ocular side effects, your mucositis, it is slightly higher. So coming to, I think this is the this is my last slide. So among the ADCs, we also have sacituzumab govitecan, or your SG. So sacituzumab initially was evaluated in the TNBC multiply relapse setting in the ASCENT trial. So there it has shown an overall survival benefit post 3 lines. And so from that, we have extrapolated the data to hormone receptor positive setting also. In this, the patients were endocrine refractory and they had received 1 to 2 lines of chemotherapy also. So SG had a PFS and an OS benefit against the investigator's choice chemo. So the PFS was around 5.5 versus 4, and the overall survival was around 14 months versus 11 months. So it had a 3 months OS delta. So if you compare all these 3 ADCs together, the only ADC thus far, with the robust data showing a PFS and an OS benefit is sacituzumab. So yeah, I think this is my last slide. So this is like a money slide, incorporating all the different lines of treatment options, right? From your first line, your CDK4 plus AI, CDK4 plus fulvestrant, then coming to your anti-PIK3 drugs, anti-AKT, PTEN, and your ESR targeting drugs, and your BRCA PARP inhibitors, then coming to your ADCs, and then at the end, we have chemotherapy. Yeah. So yeah, that's it. If there are any questions, I'm welcome to answer them.
Okay, thank you, Dr. Santosh, for setting the stage of what actually is happening with regards to the hormone-positive HER2-negative metastatic breast cancer. I would really encourage the audience to actually post the questions, but I think we'll take all those questions at the end of the 3 speakers' talk. So Dr. Santosh has kindly stepped in very early for us to be able to set the scene about what to do. I mean, in the past, it used to be hormone positive. Yep, you get, tamoxifen or AI. And then, fulvestrant comes into play, and then now CDK4/6 inhibitors. But as we all can see, that there are going to be some patients who basically progress quite early, and what do we do next? So Dr. Santosh has actually set the scene for it. But behind all this, there will be biology involved as to why we do what we do. So that comes to the next speaker, Professor Dr. Ching Hun Ling from Taiwan. He's a clinical professor from the Department of Internal Medicine, National Taiwan University Hospital. He received his MD and Master's in 2005 and completed his PhD in 2011 from the College of Medicine at National Taiwan University. He completed his residency and fellowship training in internal medicine, oncology, and hematology, so he wears multiple hats, at the National Taiwan University Hospital, and is board certified in internal medicine, medical oncology, and hematology. So over his career, he has held several leadership roles, including serving as Secretary General of the Taiwan Oncology Society and Director of Oncology Center at the Hsinchu branch of the National Taiwan University. His clinical and academic work continues to contribute significantly to the advancement of oncology practice and patient care in Taiwan. So in 15 minutes, he's going to take us through on the mechanisms of endocrine therapy resistance. Over to you, Professor Cheng. Thank you.
Thanks for Professor Nelly's kind introduction. And can you see my slides?
Yes, sir.
Okay. I'm going to talk this topic and the mechanism of the endocrine therapy resistance, and I will cover the major endocrine therapy resistance and the current therapeutic approach. Here's my disclosures. And the major mechanism of endocrine resistance can be divided into ER-dependent resistance mechanism and the alternative pathway activation. Let me start with the well-known ER-dependent resistance. That's the ESR1 mutation. From the preclinical model and the structural analysis shows that the mutation occur at ESR1 at the ligand-binding domain can lead the breast tumor cell to estrogen-independent growth. And the ESR1 mutation are the key driver of endocrine resistance. And it also a predictive marker for the tumor cell still endocrine sensitivity. That's why the tumor cell can try to survive under the endocrine therapy. And its mutation commonly occur at the ligand-binding domain shown here, and there are 11 most prevalent ESR1 mutation shown in the genomic landscape study. And the ESR1 mutation are rare at the diagnosis of advanced breast cancer, about 5%. But after 1 line or 2 line endocrine therapy and the CDK4/6 inhibitor, the ESR1 mutation can up to 40% from the three studies shown here. And the ESR1 mutation is a predictive marker for aromatase inhibitor resistance. From the combined trial of SOPHIA and the EFFECT trial shows that the patient with ESR1 mutated tumor treated with exemestane, the progression-free survival was very short. And the ESR1 mutation was also associated with poor or shorter overall survival. However, if the patient treated with fulvestrant for the ESR1 mutated HR-positive, HER2-negative breast cancer, the progression-free survival can improve to the same level as the ESR1 wild type. It suggests that fulvestrant still retain the endocrine sensitivity even in ESR1 mutation. And there are 2 major mechanisms of action of fulvestrant. One is to disrupt the ER dimerization, and the second one is to degrade the estrogen receptor. However, according to the immunohistochemical study, you can see that the ER degradation by fulvestrant seems not to be complete. And there are some next generation ER degrader, and its efficacy, their efficacy has been improved, and also their administration way also improved. For fulvestrant, you need to be intramuscular injection, but the oral SERT, they can be taken orally. And there are many oral SERT under development, and some have already been approved. And the other approach to degrade another approach to degrade the ER is the PROTAC. PROTAC can completely degrade the ER, and also the SERM and the SERCA. They can completely inhibit the downstream of the ER signaling. Because now some clinical trials have shown very good efficacy in SERT and also PROTAC. So today I will talk these two parts. And the oral SERT can be used as a monotherapy as a second line or later line in mutated ESR1 HR-positive, HER2-negative metastatic breast cancer. From the EMERALD trial and the AMBER trial, it shows that elacestrant or imlunestrant can improve the progression-free survival when compared with fulvestrant or standard of care. However, still about 30% of the patients did not respond to fulvestrant or oral SERT. And the advantage of the oral SERT is the about 20 to 30% of the patients can have longer disease control. And because to overcome the primary resistance to fulvestrant and oral cert, another approach is early switch to oral cert upon the ES1 mutation. And when patient had the ES1 mutation detection and without radiology progression, they are called the molecular progression. And for patient with molecular progression, to randomized trial, the PADA-1 trial and the SERENA-6 trial shows that early switch to fulvestrant or camizestrant can significantly improve the progression-free survival. And you can see the early separation of the two curves. And in PADA-1 trial, the hazard ratio is 0.61. In the SERENA-6 early shift to switch to camizestrant, the hazard ratio is 0.44, and they can have more longer disease control rate when compared with the standard of care. Another approach is the PROTAC, the proteolysis targeting chimera. Its structure contains a linker with two active domains, and one domain can link to E3 ligase, and another one is linked to ER. So they can use the ligase to degrade the estrogen receptor completely, and it can also be recycled. And from the randomized phase 3 trial, the FairyTech 2 trial just published in New England Journal of Medicine, it shows that vatiquinone compared with fulvestrant can significantly prolong the progression-free survival with a hazard ratio 0.57. But still, as a monotherapy, they still have about 30% of the patients did not respond to giredestrant. And its efficacy from the indirect comparison of the hazard ratio seems to be quite similar to that observed in the EMERALD trial and also in the EMBER-3 trial. And the progression-free survival trial are also quite similar. So their efficacy generally seems to be similar. And another major endocrine resistance mechanism is alternative pathway activation. Let me start with the upper part, the receptor tyrosine kinase part. And the growth receptor, including the FGFR, EGFR, and the HER2. And the HER2 and the ER are well known, have well known crosstalk. Because in the HR positive, HER2 positive breast cancer, when we treat the patient with anti-HER2 treatment, the ER pathway can be activated. It has been clearly shown in a translational study when we treat a patient with lapatinib. 2 weeks later, do the tumor biopsy, the ER expression can be upregulated, and it's correlated with BCL2 increase. And their crosstalk may not only occur at the upper in the ER and the HER2 in the receptor level, and also in the downstream level. For example, the ER downstream is the CDK4/6 and the cyclin D1. And the cyclin D1 and the CDK4/6 axis can increase the phosphorylation of the mTOR downstream. It can increase the phosphorylation of the 4EBP1 and the S6 kinase. So their downstream also have strong crosstalk. So to inhibit the downstream, like a combination of the cyclin and CDK4/6 inhibitor and the PI3K pathway, or combination with anti-HER2 treatment, can have a synergistic effect. In clinical trial, the randomized phase 2 trial, MONARCH trial, to test the combination of anti-HER2 with endocrine therapy and the CDK4/6 inhibitor as the third line or later line metastatic breast cancer. It shows that a triple combination anti-HER2, anti-ER, and the CDK4/6 inhibitor seems to improve the progression-free survival. And as the maintenance trial or the first line trial, both two trials, the DETECT-5 and the PATINA trial, shows that a combination of endocrine therapy with anti-HER2 treatment and the CDK4/6 inhibitor can improve the progression-free survival also. PATINA trial is a phase 3 trial. It shows that after 6 to 8 cycles of the chemotherapy plus anti-HER2 treatment, and the maintenance trial adding the palbociclib to anti-HER2 and the endocrine therapy can improve the progression-free survival up to 44 months. So it's quite long. So the synergistic effect seems to be quite clear. And the downstream of the growth factor receptor is the major pathway is the PI3K, AKT, and the mTOR pathway. And we have the PI3K inhibitor, AKT inhibitor, and also the mTOR inhibitor. Now we have 2 PI3K inhibitors and 1 AKT inhibitor and the mTOR inhibitor. They share some efficacy, but however, they still have some difference. For example, the predictive biomarker are quite different. For the PI3K inhibitor, alpha inhibitor, or alpelisib, its efficacy depends on the PIK3CA mutation status. For everolimus, BOREAL-2 trial shows that PIK3CA mutation actually is a prognostic marker, but not a predictive biomarker. And in the middle is the CAPItello-291 trial. The capivasertib efficacy, the biomarker favor, for example, the PIK3CA mutation, AKT or PTEN genetic alteration can predict slightly better efficacy to AKT inhibitor capivasertib. But for pathway non-alter, these two curves still have some kind of separation, although US FDA only approved capivasertib to be used in tumors with AKT pathway alter. And one genetic marker also different to predict the efficacy in PI3K inhibitor and the AKT inhibitor is PTEN, because we know that the PTEN can return the PI3K from active form back to the inactive form. So prior translational trial shows that when a patient treated with alpelisib and in multiple organ biopsy shows the conversion dose of the PTEN dose, and it suggests that PTEN is an important resistance mechanism to PI3K alpha inhibitor. And another study also shows that use of the PI3K inhibitor in patients with PTEN genetic alteration, none of these 4 patients get a benefit from alpelisib monotherapy. So PTEN is a predictive resistant to PI3K inhibitor. However, AKT inhibitor is different because the AKT inhibitor capivasertib is at a central regulator. It seems to be a master switch in this pathway. And compared to that occur in the PI3K inhibitor is different because the PTEN alteration predict the capivasertib past fulvestrant efficacy, and it can significantly prolong the progression-free survival with a hazard ratio of 0.43. And the next part is the cell cycle. The cell cycle we know the well-known is the CDK4/6 inhibitor. However, there are still some transcription factors like the MEK signaling also play the endocrine resistant mechanism. And how to overcome the downstream resistance, and I have already mentioned that actually we can also combine the CDK4/6 inhibitor with the PI3K, AKT, and the mTOR inhibitor, and because they have also strong relationship crosstalk. Now the first successful story is INAVO120. Combination of the PI3K inhibitor plus CDK4/6 inhibitor plus the endocrine therapy shows a very good result to improve the progression-free survival and the overall survival. And in following trial, we need to see the CAPItello 292 to see whether the combination of the AKT inhibitor can also achieve similar efficacy as a PI3K inhibitor. And the most difficult part is to target the transcriptional factor, because we know if we treat, we have already overcome the ESR1 and the PI3K pathway, and the death part is the MEK. And recently, the KAT inhibitor shows this may be promising. KAT is a lysine acetyltransferase. They can accelerate the lysine residue. For example, the KAT6A or B can accelerate the lysine residue 23 to histone 3. So it's named as H3K 23AC. And it can promote the chromatin promoting gene transcription, and they can upregulate the gene transcription involved in the cell cycle regulation, estrogen signaling, and also MEK signaling. To inhibit the KAT6A can block this pathway. And in the phase 1 trial, shows that the combination of the KAT6A inhibitor with fulvestrant can increase the response rate up to 30% in the patient who have already failed the CDK4/6 inhibitor and the endocrine therapy. And its efficacy seems to be also still quite good in the patient who has a third line treatment or later line treatment. Even in a patient with P3CA mutated tumor, its median progression-free survival still can be 7.2 months. And that's my last slide. The take-home message is ESR1 mutation is a major resistance mechanism. And they can be the oral SERT can be used as monotherapy or early switch oral SERT in the molecular progression. So next generation endocrine therapy also include the PROTAC, also show quite a good progression-free survival in ESR1 mutated tumor. Co-targeting resistance mechanisms such as the combination the anti-HER2 treatment, endocrine treatment, or maybe with the CDK4/6 inhibitor or PI3K AKT/mTOR inhibitor signaling can enhance the endocrine therapy efficacy. And the capivasertib is effective regardless of alteration type. For example, the P10 predict the PI3K alpha inhibitor resistance, but its effect is a predicted biomarker of the AKT inhibitor. Novel epigenetic therapies such as the KAT6 inhibitor are promising to replace the ER transcription. That's my last slide. Thank you.
Thank you, Professor Cheng. Actually, your talk is actually quite difficult to actually present with lots and lots of new things. I think for the audience, and my personal experience is that when I saw Professor Cheng's slides, I actually thought that, it takes some time to digest, and I'm not sure whether, everybody can take in his message in such a short period of time. But I really think that his slides are beautifully illustrated. And I don't know if AstraZeneca will be willing to share the slides later on, because I think these are really, really important part of our knowledge as to know why, down to the molecular level, why some of the patients progress quickly or some of the patients do not respond to the typical type of hormone manipulation. So we'll move on to our next speaker, Professor Nadia Habak. I think we all know her. We've seen her talking in person and also over the internet. She's kindly agreed to give us a talk for 30 minutes. And I would like to introduce her. She's the ESMO Director of Education at the LMU University Hospital, Munich, Germany. She's also holding the chair for conservative oncology at the Department of Obstetrics and Gynecology at the LMU University Hospital, Munich, Germany. She leads many, many trials in breast cancer, ovarian cancer, and she plays a pivotal role in complex clinical care and research. She serves as a steering committee member of the Munich Comprehensive Cancer Center and is a member of the Institutional Review Board of the LMU Medical Faculty from 2016 to 2022. She's not only the current Director of Education, she has also served as a subject editor for breast cancer in ESMO guidelines. So all the guidelines that we see, she's had a hand in it. And she's got a long-standing membership at the ESMO Breast Cancer Faculty. Her contributions are very widely recognized, and she actually has received the 2020 ESMO Lifetime Achievement Award, 2023 German Cancer Award for Clinical Research, and many distinguished honors for her leadership in clinical and translational research. So Professor Nadia will bring us optimizing outcomes in hormone-positive, HER2-negative breast cancer and what's new. Professor Habeck, over to you.
Thank you so much. If you allow me to share my slides. Yeah, let me see. Can do that. So you should be able to see my talk now.
Yes, ma'am.
Wonderful. So thank you very much for having me this evening, and I'm really grateful to the two previous speakers for sort of setting the scene, both from a clinical as well as from a translational point of view. So my job is now to sort of summarize what you've already heard and put this into our clinical treatment algorithms for hormone receptor positive, HER2 low, HER2 zero, HER2 negative, whatever you want to call this, metastatic breast cancer. Here are my disclosures. And I'm going to be talking about the guidelines, then about endocrine-based approaches, go through the lines of therapy with the focus on the novel things that are approaching and that we can already use in clinical practice, then talk a little bit about the replacement of conventional chemotherapy by antibody-drug conjugates, and then look at future developments. But I think at the end we'll have some cases also to see how we implement that actually in clinical practice. If we look at the hormone receptor positive, HER2 negative metastatic breast cancer, I think we all agree it's a very heterogeneous and complex disease with a lot of dynamics in some cases, but also very slow progression in these endocrine, more sensitive cases. And there's a lot of biomarkers we need to assess in order to treat our patients properly. And you've already heard that in the first talk. If you look at the changes in metastatic breast cancer, we can see that here, and this is just from Monarch 3, which is a first-line trial, as well as the next Monarch, a late-line trial. You can see that with each line of therapy, you have more molecular alterations. There are some that are quite stable. I'll get into that a little bit later, but you can also see that the ESR1 is something that's developing under treatment pressure, and that is something that we can target in later lines, in early breast cancer, as well as in the first line. The likelihood of having an ESR1 mutation is actually very low. We've had very fast progress in this kind of metastatic breast cancer, as in other subtypes as well. And if you look at here at the timelines, you can see that from the 1970s to almost the 2010s, we only had endocrine therapies. And then we had a very rapid succession of new targeted therapies, everolimus being the first one, then the CDK4/6 inhibitor story we had beautifully in the first presentation already. And then all these drugs that the second speaker talked about when he mentioned the endocrine resistance pathway. And I will get through some of these studies in more detail to tell you what we do in clinical practice. If you look at the endocrine therapies and the estrogen receptor signaling pathway, obviously we can stop the production of the ligands and inhibit the change from androgenic precursors to estrogens, which is the AIs. Then we can basically replace the ligand on the receptor with a higher affinity, which is our SERMs, and then we can degrade the estrogen receptor, which is where the SERDs come in. And this is particularly helpful in patients with an ESR1 mutation. So if you look over the treatment pathway of patients with this subtype of metastatic breast cancer, they're initially, most of them are really endocrine therapy sensitive, and that sensitivity, as we beautifully heard in the last talk, decreases over time and impacts obviously treatment benefit as well as in more recently, because we have alternatives, our treatment selections. So the ESMO guidelines, and I'm very proud to say that because I put a lot of work in the last couple of years in the ESMO guidelines, as our chair kindly pointed out. We have a living guideline that's the second living guideline that's been updated in April of this year, just before the ESMO breast meeting. And we're going to have the new ESMO metastatic breast cancer guideline with a full publication in Annals of Oncology very soon, with the first author being Dr. Diajambouya from Belgium. And obviously there is also the wonderful PAGA guidelines with the Pan-Asian adaptation of the ESMO guidelines, which I had the honor to work on over the last two editions in early and metastatic breast cancer. And I have to say that the discussions with my colleagues from all the different Asian societies really was very insightful, and I cherish that work a lot. Let's look what we changed here. And you can see the first line, basically, as you heard from the first speaker, the CDK4/6 inhibitors as standard of care, usually combined with an AI. And then, and I pointed this out here with the green arrow, we always, at every progression, first of all, we think about the additional testing. And we heard that in the second talk, and I'll go into that a little bit later. But then we also have to think about whether the patient is still a candidate for endocrine-based approaches. And we don't give you exact criteria because all of us as clinicians have a certain feeling, I think, to see whether patients actually can take one more line of endocrine-based therapy. And sometimes that it's not the case, and then we go to chemotherapy directly, and that will be addressed at the end of my talk. So for the CDK4/6 inhibitors, I'm not telling you anything new here. We have the 3 drugs that you already heard about, and we have all the registrational trials. Some of them, and this you have to be careful here to look at the absolute differences, because some of them have a little bit higher percentage of endocrine resistant disease in their populations. Mostly the palbociclib trials, both in first as well as in second line, have a little bit more endocrine resistant populations, and that may explain some of the results. All of them double PFS, and I think this was what makes these drugs so special, that we want our patients to have more progression-free survival, and that translates into overall survival benefit in only the ribociclib trials on a consistent pattern. With the abemaciclib trials, you see that, but in the first-line setting, for example, that is not statistically significant, although clinically very meaningful with a 12 months difference. And with palbociclib, these trials did not reach statistical significance, but I already said that this may also have to do with some of the population that were included in these trials, but all of these drugs show substantial PFS benefit, and as I said, some show overall survival benefit. And I think the reason that not all of them show overall survival benefit is partly due maybe to the drug itself, but also to the therapeutic setting the trial was placed in. And then we have a new option, which in Europe just became available very, very recently. We don't have the drug on the market. We expect this to be the case after the summer break. But inavolisib is approved in Europe now, and in Germany we have the advantage that we can use the drugs once they're approved in Europe and they get reimbursed, and then the company has 1 year to sort of sort the price out with the government, but we can still prescribe to our patients. So we just started to use inavolisib in that setting of endocrine resistant disease, based in the first-line setting, based on the data of the INAVO 120 trial, which included patients with a PIK3CA mutation, either in tissue or liquid biopsy, and progression during or within the first year after completion of adjuvant endocrine therapy. And the trial compared the triplet combination of inavolisib, palbociclib, and fulvestrant versus just palbociclib and fulvestrant. You can see here, this is from the talk this year by Nick Turner at ASCO, where he showed the updated PFS benefit with a strong hazard ratio of 0.42. And what we also saw was, and I think that is quite amazing, is that we have almost 3 times as much objective responses in the inavolisib arm, which is very important because if patients are symptomatic, this is what makes them feel better immediately. And so this is very strong data. I think that the triplet actually reduces the tumor burden quite effectively. And the duration of response, we have a difference of in the median of about 8 months. And then obviously important for patients as well, there's more than 2-year difference in the time to first subsequent chemotherapy. So what we get by using the triplet right from the beginning is a very strong effect on the tumor burden, which is long-lasting as well. But I think the most exciting data we saw was the overall survival benefit here, with a difference in median of more than half a year and a hazard ratio of 0.67. So very strong data. I think inavolisib will be readily implemented. And one of the reasons is that it has the PI3 kinase inhibitor associated side effects, but they're all numerically, if you look at the grade 3 and 4 side effects of the bold items like stomatitis, hyperglycemia, diarrhea, rash, you look at the grade 3 or 4 toxicities, it's less than 10%. So it's much more tolerable than previous, not as PI3 kinase inhibitors that were not as selective. And there is some ocular toxicities as well, but they are not anything structural and reversible. So I think also the discontinuation numbers show this very nicely, less than 10% discontinuations based on side effects in the INAVO arm, which is still more than the placebo arm with the CDK4/6 inhibitor, but I think this is within the range that we see for these new targeted agents. Obviously, we have to take care in patients that have diabetic situation already. We have to make sure that that is well controlled before we start the therapy. But other than that, I think this is something that will be very, very manageable. And there is also some hematological side effects, mostly thrombocytopenia, which is something we just have to keep in mind. And then in the second line, and you already heard that presented very nicely, we have a need to have further biomarkers evaluated so we can make a proper decision in those patients that still had responded well to the first-line CDK4/6 inhibitor and still have a chance for another line of endocrine-based options. And here PIK3CA mutations are needed, ESR1 mutations, and the germline BRCA status together with PALB2 is also something that we need to know. And then obviously in patients without a biomarker, we can still switch the CDK4/6 inhibitor or give everolimus. And here's the data for the CDK beyond progression, which I think is interesting, but it's not mind-blowing. So I think in Germany, we're very reluctant to use that strategy because, as I said, we have all the other options available as well. So if we have a biomarker present, obviously we would not go for CDK4/6 beyond progression. Still, I think these data are very important because more and more of our patients now receive ribociclib or abemaciclib in the early breast cancer setting, and then obviously first-line therapy would be CDK inhibitor beyond progression. So I think it's interesting to see that we probably, if we want this to be a successful treatment step, we need to change both the CDK4/6 inhibitor as well as the endocrine backbone. At least that's what the MAINTAIN and also post-MONARCH trial tell us. And then coming back to other biomarkers, obviously the AKT pathway alterations, including PIK3CA mutations and PTEN alteration, is something that is targetable, with PIK3CA mutations being here the largest proportion of these biomarker alterations. This is a rather stable alteration, and so we can also use primary tumor tissue if we don't have anything else available and cannot do a liquid biopsy in order to see where there is a AKT pathway alteration. And then we also have the ESR1 mutations. As I said, they become more frequent across the lines of therapy. And in patients with a late line situation, we have about 30 to 40% ESR1 mutations. I think overall, the percentage is rather more like 20%, at least from our experience. And then if you look at the how deep you have to go into these pathways in order to inhibit endocrine resistance from taking place, I think this is very nice cartoon. But we also know that mTOR inhibitors, for example, although this is part of the AKT PI3 kinase pathway, like everolimus, they work without any biomarker. The Capitello study with capivasertib, we already heard about the phase 2 predecessor study, and it was in patients with a quick recurrence after adjuvant or with less than 3 lines of endocrine therapy in the metastatic setting. Patients could have had 1 line of chemotherapy, and capivasertib was added to fulvestrant in a placebo-controlled fashion. The registration is for the AKT pathway altered population only, although we also saw activity in the overall population, and there's a significant, but also I think clinically meaningful doubling of the progression-free survival and time, and we're looking for the overall survival now, given the fact that the Phakion trial, the predecessor phase 2 trial, showed an overall survival benefit. I think this is going to be very exciting. The other options are alpelisib, which is a PI3 kinase inhibitor. In Germany, it's not available because there was no agreement about the pricing with the manufacturer, so we have to import it from other countries if one patient needs it. I think with capivasertib now being available, alpelisib use will be less and less, also because there is substantial toxicity associated with it. But the SOLA-1 trial nicely showed that alpelisib works together with fulvestrant, but only in patients with a PIK3CA mutation in their tumor. As there were hardly any patients with CDK4/6 inhibitor pretreatment in the SOLA-1 study, the BYLieve trials were started where it was just a single-arm cohorts based on the previous endocrine therapy, where was 1 arm with fulvestrant and 1 with an AI. And you can see here that the overall response rates as well as the progression-free survival are quite decent, also in patients with the previous CDK4/6 inhibitor treatment. So it's a good option. I think we have now more modern options that are less toxic, so it depends on availability, obviously, whether you use alpelisib or not. But it certainly works and inhibits progression in PI3 kinase mutated tumors. Everolimus, it's old but still good. We have data showing that it works quite well. There's also newer studies like this one here, where patients had pre-treatment with CDK4/6 inhibitor. There's also some retrospective analysis showing that everolimus works after CDK4/6 inhibitor. So I think it's still an option. We also use it in patients without targetable biomarkers. And then obviously we have emerging mechanisms of actions in the way of anti-estrogen treatments. Today, we're not going to talk about those protaxerins and Circas because these drugs are not available yet in the clinical setting, but I think it's reassuring to know that there will be more options. And I think then in the end, the efficacy, but also the side effect pattern and obviously access and pricing will play a role in which drugs will make it to the market. But I think there will be more endocrine-based options in the future. With regard to ESR1 mutations, you already heard that elacestrant is our approved option, was approved based on the EMERALD study. And you can see what the previous speaker also highlighted, that in the EMERALD study, which was a later line endocrine-based trial, you can see that about a third of the patients, the curves drop off. So there is until the first restaging. So there is certainly patients for whom endocrine options, at least endocrine monotherapy, are not a good option in later line settings. So having said that, the drug was approved in the ESR1 mutated population, given its good hazard ratio and a significant improvement of progression-free survival in a hazard ratio of 0.55, which is quite strong, but overall the times are a bit disappointing in this late line setting for an endocrine-only therapy. What we've also learned for elacestrant, and please keep in mind that the comparator here is an AI or fulvestrant. You can see the longer the benefit to the previous CDK4/6 inhibitor is, the better elacestrant performs compared to the comparator, which is always a median PFS of just about 2 months. So elacestrant really makes a difference in endocrine sensitive disease. It probably does not make much of a difference in endocrine resistant disease as a single agent. And then we have other drugs coming up. Imlunestrant, the EMBER-3 trial, I have to say I'm biased because obviously I was part of the investigators here and I'm also a co-author on the publications, but I think it's an interesting trial because it looked at an oral SERD by itself versus standard of care, but also looked directly at the combination of CDK4/6 inhibitor and the oral SERD. And I think this is quite telling data. You can see here the oral SERD performs as expected, improves PFS in patients with ESR1 mutations, but there is again this drop at the beginning because for some patients an endocrine monotherapy is certainly not the best way forward. And then you can see here that the imlunestrant plus abemaciclib actually outperforms imlunestrant alone. And this is independent of biomarkers, be it ESR1 or PIK3CA. So you can always, if you combine the oral SERD, you will probably get a better outcome for the patients, and it's not so biomarker dependent. So we'll wait for the approval and wait what the regulatory authorities make of this quite innovative trial design. And then obviously there's also, as we already heard, camizestrant in the SERENA-6 study, which is another oral SERD, but not just an oral SERD. It's also a very innovative trial design because it looked at patients with developing ESR1 mutation. And you can see here that a lot of patients, over 3,000, needed to be tested with liquid biopsies every 2 to 3 months in the follow-up. And then those patients where you had ESR1 mutations detected, that these patients then were further screened. And we see that quite a substantial number discontinued and could not be entered into the trial. And a lot of these patients already had concurrent disease progression, which was picked up by imaging, but first detected by liquid biopsy. Then 315 patients were randomized, and we saw an improvement in PFS with a strong hazard ratio of 0.44, also an improvement in PFS2. So this will probably go to approval, and we'll see what the authorities say, whether we have to implement ESR1 mutation screening now in our first-line treatment with AI plus CDK4/6 inhibitor. I think a very innovative trial design. I think it's interesting to see. I'm not so sure that we would like to do a mutation screening in every patient, because some patients are very stable for 5 or 6 years, but we could probably try to do it in the beginning in order to pick out those patients with a fast progression where we can help them. Ultimately, in order to take this management procedure with the liquid biopsy retesting at a regular basis forward, I would love to see an overall survival benefit of changing early based on molecular progression. The side effects are very moderate with this CDK, with this oral SERD camizestrant. Doesn't have a lot of problematic side effects, not the ones that we expect from some of the oral SERDs, where there were some cardiac problems and also some GI toxicity. There was some brief flashes in the peripheral vision, which didn't impact daily activities, so we'll have to see how this pans out. And just one point before we move forward, if there is quite good data that patients in the metastatic setting, and this is particularly here for the HR positive subtype, will not come to the next line of therapy. So if we have something that is very good in prolonging progression or affecting objective response rates, it does make sense once you have access, once it's approved and reimbursed, to use this possible, because some of the encouraged from having more treatment, the family influences them in that direction. So it's always good to give the best medications first. So if we have a chemotherapy indication, which eventually comes, maybe in endocrine sensitive disease after 2 or 3 lines of endocrine-based options, in endocrine resistant disease with only a short benefit from the first-line CDK4/6 inhibitor, I think the chemotherapy indication will come very soon. Here you can see that the guidelines have changed dramatically. We now have TDXD in HER2 low or HER2 ultra low based on DB06, even in the first line setting. And we also have obviously chemotherapy. In Europe, we can use bevacizumab. It prolongs progression, doesn't prolong survival, but it's still used, mostly though in triple negative disease. And then if patients have prior chemotherapy, we have TDXD approved, and we have sacituzumab and datopotamab approved. And then after we run out of ADC options, regular chemotherapies obviously are also a good way to slow down progression. If we look at the HER2 status, I think we saw major change with the advent of TDXD outside of the HER2 truly positive spectrum, with now that we take more care of how much staining there is, even if it's not overexpressed. And the 1+ are important, but also in the former IHC zeros, if there is membrane staining in 1 to 10% of the tumor cells, this could be an HER2 ultra low and would have qualified for DB06. We have the 3 ADCs. You cannot cross compare these trials. You have to go trial by trial and see what the efficacy are. The trials differ a little bit with regard to the included patient populations, and TDXD has the earliest trials if you go by line of therapy, and obviously there's also some differences. Sacituzumab is given day 1, day 8. The others are given 3 weekly. So there is some differences that also may impact on decision making. If you look at the datopotamab in the TROPION-01 Breast-01 study, which was a plenary at ESMO, some 2 years ago, you can see that there is a benefit in progression-free, although not in overall survival. Although I have to say that with the new drugs coming along and ADCs being available in clinical practice, also outside of trials, we will have higher rates of clinical crossover and then maybe not see such wonderful overall survival benefits like we, for example, saw in the DB04. So good data, but no overall survival benefit, but certainly another option in this setting. Then we have the DB04, which was practice changing, had standing ovations at ASCO because it was the first trial of its kind to show that an ADC actually provides benefit in hormone receptor positive setting with a strong impact on progression-free as well as overall survival with a half a year overall survival benefit. So really strong data made it into the guidelines immediately, needs to be implemented. The DB06, we don't have overall survival data yet. It's a bit earlier. We know TDXD in the first line setting in HER2 low and ultra low prolongs PFS compared to standard of care chemotherapy. You can see that the benefit is quite similar in all of these HER2 subgroups. And then we saw some very interesting data at last year's San Antonio by Aditya Bardia, who showed us that, coming back to what I said earlier in my talk, that we have patients with a slow progression and patients with a fast progression after CDK4/6. If you go to the left side of the slide, you can see that TDXD provides substantial benefit in those patients that only responded less than half a year to CDK4/6 inhibitors. So independent of endocrine resistance status, TDXD is a very good chemotherapy-based option in these patients. And another point to make is that TDXD provides benefit independent of biomarkers. Like here you can see PIK3CA mutations, yes or no. And this is very recent data from Rebecca Dent's talk at ASCO this year. And independent of ESR1 mutations, TDXD outperforms standard of care chemotherapy, and also independent of BRCA mutation status, although please keep in mind that the subgroups here are getting very small. That's why you see larger confidence intervals. So in summary, in hormone receptor positive, HER2 negative metastatic breast cancer, things have become complicated. We need biomarkers. You can see here, this is from the German guidelines, basically very similar to the ESMO living guidelines. And you can see that after several lines of endocrine-based therapy, we go to ADCs directly. And I think one of the open questions we have, maybe we can discuss this at another meeting in a year or so, is obviously how to sequence those ADCs. And we have first data here from this year's ASCO, but also in San Antonio, we saw some data that the first ADC, independent of, in this case, whether it's TDXD or SG, always has the better impact, except for some exceptions. So in summary, I think in hormone receptor positive, HER2 negative metastatic breast cancer, I think in the first line settings, we have the CDK4/6 inhibitors that are standard of care. And then we have to make sure that the patients in the subsequent lines get the best possible treatment as early as possible. We would love to offer 1 or 2 lines more of endocrine-based therapy, particularly in those patients with a targetable biomarker. And then after endocrine-based therapies are not effective enough anymore, ADCs have started to outperform conventional chemotherapy. So I think these are exciting times. They give us lots of choices, our patients lots of choices, although talking from in front of an international audience, obviously access and availability are key for these drugs. And with that, I just want to highlight we have enough time and opportunities to discuss again with each other at ESMO this year, which is in Berlin, in Germany. So I hope some of you can make it, maybe even just in the hybrid version. And then obviously ESMO Asia, which is in this early December, just before San Antonio in Singapore, and is always very good forum to discuss with my Asian colleagues. And with that, I would just like to thank you for having me and looking forward to the discussion.
Thank you, Professor Habeck, for tying the first two speakers' talk together from the initial part to the molecular part. And now, due to the interest of time, we'll just move on straight to the panelist discussion, omitting the case-based panel discussion. But I would also like to introduce two other panelists who's going to join us right now. And the first one will be Dr. Atul Batra, who is the Associate Professor Medical Oncology in the All India Institute of Medical Sciences, New Delhi, India. And he's had over a decade experience in managing various malignancies, including breast and genital urinary cancers. And he's a recipient of the ASCO Innovation Grant in 2021, Coleman Scholar SABS Award, ASCO Merit Award, and ESMO Young Investigator Award in the year 2020. And our second panelist, Dr. Rhoda Joseph, is an Associate Professor in Medical Oncology, Regional Cancer Center, Trivandrum in Kerala, India. And she also has got more than a decade of experience in managing solid tumors and has her interest in breast, GU, and gynae cancers. And I would also like to invite the previous two speakers, Dr. Akhil Santosh and Professor Chen, to join in our discussion. I would encourage the audience to type questions so that we can address to all our panelists here. So to begin with, perhaps I will actually open the floor. We talk about endocrine resistance. Maybe we make it kind of like very basic. How would you define endocrine resistance, perhaps in a de novo metastatic breast cancer? De novo, firstly, newly diagnosed. Anybody?
We usually take any disease which is progressing within 6 months in the case of de novo metastatic breast cancer as endocrine resistance.
So within 6 months of endocrine therapy. What about those who's had adjuvant endocrine therapy?
Adjuvant, it's mostly 2 years. For an adjuvant, it's 2 years, and in the metastatic setting, it is mostly 6 months.
Any other definition, Professor Habeck? The definition of endocrine resistance.
I think what the colleagues said are the definitions that we have in the guidelines. I think in the real world setting, we don't go by these definitions. We would always, if there's a slowly progressing disease, we would always give the patient a chance for an endocrine-based approach, even if there is rapid progression, but depends on the disease dynamics. But I think the guidelines are good. So at least when we have these trials, we're talking about the same populations, which wasn't the case in the past. But if it's, I mean, in ovarian cancer, we got away from the platinum resistant, platinum sensitive, just based on the timing of the imaging. And I think we should do the same in treating our patients in metastatic breast cancer.
Would it be the same in Taiwan?
Yeah, I totally agree with Professor Habeck's comment, because the guideline, although we know the guideline, for example, the primary resistance was defined by adjuvant treatment relapse during in the first 2 years of adjuvant endocrine therapy, and the secondary resistance is after 2 years, but within 12 months completion of endocrine therapy. And for metastatic settings, the primary resistance was defined as less than 6 months of the endocrine therapy or endocrine therapy plus CDK4/6 inhibitor. However, maybe it's not so important to memorize all of the definition, because it's important for clinical trial recruitment to make the population more homogeneous. However, for clinical practice, usually we still need to see the growth pattern of the growth rate of the tumor, and also to see the tumor burden and the endocrine receptor expression amount percentages. So we need to consider that not only the primary or secondary endocrine resistance.
So what Prof. Chung is saying is that it's not just about the time to progression, but also the tumor burden. Yeah.
Yes.
Okay. Maybe I open the question about liquid versus tissue biopsy. Now, as we heard from the speakers, we heard that, with PIK3CA mutation, it's something that, is stable at the time of diagnosis versus the emergence of the ESR mutation over the period of time, especially you're getting the endocrine treatment. Let's just ask about India. Would you actually do liquid tissue biopsy? Is that something, a routine practice outside clinical trials?
Yeah, we do actually now, especially ESR1 mutations, we have started doing in breast cancer, and in lung cancer, we've been doing it for a long time. So there are validated assays that are available. Although we have limited access to elacestrant, and then the kind of patients who benefit with elacestrant is also limited, as shown previously as well, that those who have responded with endocrine are more likely to respond. Otherwise, it's a modest kind of response. So we do use liquid biopsies and getting kind of assays on the liquid biopsies.
Are you just doing ESR mutation, or are you doing a
We
broad?
do a more comprehensive panel that's available. So there are several panels that are available, but we should be covering at least ESR1 and PIK3 and then mutations. That's what we try to cover. Those are the targetable ones that stay with breast.
Dr. Joseph, you have anything to add?
Yeah, at our center, routine ESR1 testing is not done because of the unavailability of the elacestrant drug. For PIK3C, I prefer to do the tissue biopsy. From the initial or from the metastatic site, we prefer to do the tissue biopsy.
And you mentioned about the tissue biopsy. Would you do it at the metastatic site, or would you do it at the, the primary site? Because there is heterogeneity, isn't it?
But I don't think that is very significant for this PIK3CA mutation. If it is there, it will be there in both specimens.
Professor Harbeck, you've got anything to say about that?
No,
Primary versus metastatic, yeah?
We do liquids, and we now change because, as I said in my talk, inavolisib has been made available very recently. We now change to doing this in the before we start first-line therapy. We used to do the biomarkers after progression to first-line therapy. Now we have to do this in those patients with rapid progression after adjuvant already at the beginning of first-line therapy. And all the others that come like after 5 years, 6 years, 7 years, or whatever, we would do a liquid after they progress on first-line CDK4/6 inhibitors. So and tissue we do in the late line when we have no other standard therapies available. We do NGS. That's a nationwide program right now in Germany, also outside of breast cancer, to see what the utility of these NGS analysis is for cancer patients.
So would you define your different sort of testing, liquid biopsy for ESR mutation or tissue biopsy, on the basis of the definition of the endocrine resistance? Because if you look at your INAVO 120, it's those that endocrine resistant, whereas you're looking at those who are on CDK4/6, you're looking at maybe ESR1 mutation, as based on the SERENA-6 trial.
For SERENA-6, we cannot implement right now. We only get reimbursement for doing ESR1 mutations twice annually. So the whole SERENA-6 concept is not implemented in our country right now. And as I said in my talk, I still have some inhibitions to do this in patients with a good long response, because I feel that if they do well on a CDK4/6 inhibitor for a long time, as long as I don't know whether there's an overall survival benefit by changing earlier, I would just wait for clinical progression. And we do actually a lot of monitoring of our patients with tumor markers. If they have been high in the beginning and then they drop nicely during therapy, we just do repeat tumor markers and don't do imaging if the tumor marker stays low, just to save costs.
So I think one of the audience actually asked, in practice, and I think you've answered that. In practice, would you be willing to test ESR mutation without progression? And if yes, at what frequency and for how long and what method? So I think I'll pass this question back to Dr. Batra and Dr. Joseph. The ESR mutation.
No, SERENA-6, no. We would do it typically at progression, and that too kind of with those patients who can bear out-of-pocket expenses for L-assistant. So it's not available. So this would be kind of limited only at progression. SERENA-6, no way, we are not yet there.
Dr. Joseph?
Yeah, the same for our institute also. Out of clinical trial, we don't do ESR testing unless patient can afford to get it imported from outside, the Elacestrant.
Dr. Santosh?
No, I wouldn't do the same because it's not the trial hasn't shown an overall survival benefit yet. There were a lot of caveats associated with the trial. There was a slight imbalance in the post-progression treatments also. So taking all that into consideration, I wouldn't at this point of time.
Professor Chung?
Yeah, although I participate in SERENA-6 trial and screen several patients, but I know the difficulty of do the screen and the ESR screening. Although according to the protocol, you can do the screening after 6 months of CDK4/6 inhibitor testing. But because just like Professor Harvey mentioned that in the long run, only 40% patients can have ESR mutation, and maybe some in the later time. So in the early time, the percentage is even lower, and you can see if the population is more than 60 or 70% of the patients, actually they don't have the ESR mutation at early line, so it will be very difficult to persuade the patient to continue to do the blood sampling. And but personally, if my patient had elevated of the tumor marker just like a CA153, but without radiology progression, maybe I think this may be a timing to do the liquid biopsy to test the ESR mutation.
Any questions from the panelists? I think I've got somebody who's typed a question. I just saw it, but it's disappeared. The question has just disappeared. Okay, maybe to Professor Harbeck. So I think you alluded something about INAVO 120 with the INAVO 120 versus the Capitello 291. So where do you think we're heading in the future?
Well, I think we're heading into a much more complex treatment algorithm in the future where we have to look at the time after or on adjuvant endocrine therapy. Then we have to look at the biomarkers. And so I can only hope that all these technologies and these drugs become available internationally and that we not see such a great discrepancy between the countries. And I think this is what we also try to accomplish with the PAGA guidelines, that we sort of make sure which of the steps forward are actually necessary and which ones are just nice to have. And I hope that that will help in the individual countries.
Thank you so much for that, because I think in reality, in resource constrained countries, we are still looking at the slides that Dr. Akhil Santosh saw at the start, whereby you're looking at tamoxifen, your SERM and your aromatase inhibitors, and we do take into account that, not everybody is going to be able to afford a CDK4/6 inhibitors as well.
But they will become generic. I think palbociclib will be the first one. And I think with that, it's just going to start to make all of these innovations more accessible. And also the biomarker testing doesn't have to be so expensive. The technologies develop. And I think even NGS is not that expensive anymore. It also has to do also with the pricing within the countries.
I think certainly that's really true because the prices have come down. There's generic palbociclib now. And I think, for those who can actually get onto the CDK4/6, you've got another 2 years, of PFS before you have to start be looking at, new further novel treatments. And certainly NGS prices have come down. Okay. So I think it's now 9:40 and I would like to basically sort of thank all our speakers, all our panelists, and all the questions that has been given. And I would like to thank the team behind today's work, the AstraZeneca team, for actually allowing all of us to come from various regions to share our experience